with weight loss, loss of appetite, and fever, evening rise of temperature. So patient will be feeling more hot in the evening. Also, other than that, patient can also present with symptoms like coughing up of blood. Um, so basically, we screen the patients based on duration of these symptoms. If a patient is having cough for more than 2 weeks or fever for more than 2 weeks, or what we call significant weight loss, that is more than weight loss of more than 10% of the patient's body weight, we will be suspecting tuberculosis. So the patients with such symptoms, we call them as presumptive pulmonary tuberculosis. So also we have something called as extrapulmonary tuberculosis, that is tuberculosis that is affecting parts of the body other than the lungs. So in such patients will be presenting with symptoms similar like fever and significant weight loss, along with other symptoms like maybe swelling of their lymph nodes. So usually that will present as a lump, usually on the neck or in the axillary region or armpits. So also patient might present with any pain or swelling in the joints, or patient might present with any complaints like stiffness of the neck or disorientation. So so basically, patient doesn't need to have all these symptoms. So just to review the symptoms, it's going to be like cough for 2 weeks, evening rise of temperature, coughing up of blood, fever, and also tiredness, weight loss, and also no appetite. So any of these symptoms, we can get a clue for tuberculosis. So it doesn't necessarily mean that a patient should be having all these symptoms. So who are the people who are more prone to get tuberculosis? So this is a very important question. A person who is in his middle age, or maybe 20 or 30 years old, without any other exposure, usually is not going to get tuberculosis. So the people who are most prone for tuberculosis are going to be the people who are very young or very old. That is the extremes of age. Also, patients with malnutrition or undernutrition, and also patients, certain occupations are more prone for tuberculosis. Example, a patient who works in mostly in a very dusty environment, patient who works in mines. So all such patients are more prone for getting tuberculosis. Also, consumption of alcohol or smoking can also decrease your immunity and cause more susceptibility to tuberculosis. And immunosuppressive conditions. So patients who are diabetic, patients who have HIV, patients who are on long-term steroids or immunosuppressors are more prone to get tuberculosis. So such patients should be on the watch, especially patients who are having HIV and also patients who are having who are on immunosuppressors. So, like I said, India contributes to almost 27% of the world's TB burden. So, hence, we need to be more vigilant because tuberculosis is almost endemic in India. So, actually, the Indian government has planned something called, there's a program in tuberculosis called NTP, National Tuberculosis Eradication Program, and elimination program, and in which we want to increase the notification rate. That is, we want to increase the number of cases that we are discovering, and also we want to increase the treatment success rate, and also we want to decrease the complications caused by tuberculosis. So for this, any patients who are suspected of whatever I told you, the cough since 2 weeks and fever since 2 weeks, and also history of weight loss, all these patients, what we do, we send the samples for testing. We also screen them for tuberculosis. So how do we screen a patient for tuberculosis? So most commonly, if the patient is getting cough with expectoration, we send sputum tests. Okay, and also we can do what is called chest X-rays for the screening of any lesions in the chest. And if we get a suspicion of tuberculosis, we can go for the higher test. That is the your molecular-based test. They're called the Gene Expert, and later there's a higher test called LPA, line probe assay. So that if we are highly suspicious of the patient, we will go for these tests. Or if the patient comes positive, either in the chest X-ray or the sputum test, we will go for these tests. So mm chest X-ray is almost routine. It is cheap, easy to do, and it can be done on spot. Whereas sputum tests, we have something called a staining test. So staining tests, they are what do you call as specific. So if you are having tuberculosis and it comes as positive, the chance of you having tuberculosis is high. But if it comes negative, there is also a chance of you still having tuberculosis. Okay, so we have sputum tests, and also we have the molecular tests. The molecular tests are extremely specific, and if both the sputum test and the molecular tests are negative, sometimes we'll have to rely on what we call as radiological findings to diagnose it. So once we diagnose it, it's not the end for the patient. Tuberculosis is a treatable and a curable disease. Okay, but we require strict compliance from the patients. So once we start, usually the treatment based on which part of the body the tuberculosis is affecting is anywhere between 6 months to 12 months. So we have something called as drug susceptible tuberculosis and drug resistant tuberculosis. So drug susceptible tuberculosis are the patients who are susceptible, for whom the baseline drugs. So we have 4 baseline drugs, that is isoniazid, rifampicin, pyrazinamide, and ethambutol. So these 4 drugs, if they're sensitive, which the sensitivity of which we understand from the different molecular tests, then it is called as drug susceptible tuberculosis. So the treatment is usually anywhere between 6 to 12 months based on which part of the body the tuberculosis is affecting. So most commonly the tuberculosis affects the lungs, and for the only lung it is 6 months. So if you have tuberculosis of the meninges, that is the layer that is covering your brain, or if you have tuberculosis of the bones, then the treatment will be extended up to 12 months. So coming to the drug-resistant tuberculosis, you can the treatment, it varies anywhere between 9 months to almost 18 months. So again, that is also based on the sensitivity pattern to the different drugs. So drug-resistant tuberculosis is much more complicated than the drug-sensitive one, and usually it is a patient can get a drug-resistant tuberculosis only mostly from other patients who already have drug-resistant tuberculosis, or if they previously had a drug-sensitive tuberculosis and they did not complete their course of TB drugs that is for 6 months or 12 months, or based on the condition they had. So they are more prone for getting drug-resistant tuberculosis. So drug sensitive tuberculosis has an excellent prognosis, but drug-resistant tuberculosis has 70% has a 30% mortality rate and complication rate. So but both are treatable. Drug-sensitive tuberculosis has an excellent prognosis, especially if you are compliant with the drugs. So usually we have what is called as an intensive phase for 2 months, and a 4 month of continuation phase. So intensive phase, the patient will be given 4 different drugs, whereas in continuation phase, the patient will be given 3 different type of drugs. So what are the complications from this? So one thing, a patient can develop complications to certain drugs in the regimen, so that we can modify the regimen without any problem. But the patient will be ending with a longer drug regimen. And also, other than that, patient can develop drug resistance if the patient has not taken the course of ATT as advised by the physician. So all this is usually monitored by the government. And coming to the end of this talk, I would like to emphasize that tuberculosis is a preventable, treatable, and curable disease. I would like to emphasize on the preventable portion. So preventable is usually mostly by following basic cough etiquette. So covering yourself when you cough, and making sure that you use disposable or reusable napkins, and also following basic cough etiquette will prevent tuberculosis, along with patients who are more prone for tuberculosis getting routinely checked, and also patients who are having a lot of immunodeficiency taking what you call a prophylaxis. Okay, so we have a tuberculosis prophylaxis therapy, so TPT. So usually it's 6 months of a single drug. So it usually works on dormant tuberculous bacteria. So taking for prone patients, we can start that based on what is called TST or IGRA test. So with that, we have seen excellent prognosis and prevention of tuberculosis. Yeah. So with that, I would like to end my talk.